Okay, so it's already the 11. So I think we should start the session. So Assalamualaikum warahmatullahi wabarakatuh. Good evening to the attendees. Today is the Department of Pediatrics turn to present a case for the Clinical Pathological Conference titled Brain Fog in the Toddler. So we have a few speakers today. So Dr. Nurul Faiqah, Bahrin is a pediatric registrar in the department. She will be presenting the case. And, she will bring you through the case and discuss about differential diagnosis and how she will work up the case. And we also have Dr. Chai Jianu, who is a pediatric radiologist from Hospital Tunku Abang Besar Tuanku Aisyah Al-Hadi, Hospital Pakar Kanak-Kanak UKM. Here we also have Dr. Leong, who is a pediatric gastroenterologist from Hospital Tunku Azizah. She will be joining us online, and I think she's already online. Okay, and we also have Dr. Chong, who is our pediatric intensivist from Hospital Toddler UKM. So without further ado, I would like to invite Dr. Faiqah to present the case. Assalamualaikum and good morning. I will be presenting the first. I will be presenter. Will be the first presenter presenting regarding the started with the case illustration. This is a 2-year-old girl presented with sudden onset of abdominal posturing and limb stiffening. She has lethargy and refused to feed 1 day prior to the event. She also had a fever and flu-like symptom 2 days prior. She was born at term with a birth weight of 2.1 kilogram, uneventful antenatal period, no significant postnatal complication, and her development milestone were right for the age. She was presented to the district hospital. At that time, she was intubated for poor conscious level. She has a low-grade fever, incompensated shock, and hyperglycemia episode. She was resuscitated and stabilized with the fluid and distress boluses and commenced on the electropic support prior to the transfer. This is the further examination on the district hospital, the growth, the weight at the 10 to 25th percentile, and the height at the 50th percentile. The child is pink and not jaundiced. There is no skin lesion seen. The pupils were 3 mm equal and reactive bilaterally. There is no evidence of splenomegaly and palpable lymph node. Liver was 3 cm palpable below the subcostal margin. And neurological examination, there is a hypertonic with all deep tendon reflexes accentuated and outgoing data response. So we move to the initial laboratory investigation done in the district hospital. The white blood cell is 16.7 with HP of 11.6 and platelet is 186. We have a urea bit cleavage with 7.5, have a mild hyponatremia, sodium of 133 and mild hypokalemia with the potassium of 3.1. Creatinine is 5, calcium is 2 and magnesium is 1.36. Random blood sugar is 10 millimole on dextrose 10% infusion. She has a severe transaminitis with AST of 8,530 and ALT of 8,032. He has a direct hyperbilirubinemia with bilirubin of 100, then 101 bilirubin of 70, direct bilirubin of 71. Based on this initial presentation and presentation, physical examination and investigation given, I will discuss more on the differential diagnosis, further history and assessment and investigation I would like to obtain from the parents. So from the summary, this is a critically ill 2-year-old girl presented with acute encephalopathy, preceded with 2 days history of low-grade fever, reduced feeding, and flu-like illness. On examination, she has an upper motor neural sign with hepatomegaly. Clinically, child in shock and hypoglycemia episode. Initial investigation shows severe transaminitis and conjugated hypovolemia. Based on this presentation, I would like to subject my differential diagnosis into major etiology. I started with the infectious, which is a viral encephalitis and sepsis-associated encephalopathy. My third differential diagnosis is acute liver failure with hepatic encephalopathy. For metabolic, is inborn error of metabolism. And then the differential diagnosis is acute toxic ingestion, Rice syndrome, and acute erythritizing encephalopathy. We will discuss regarding the first differential diagnosis first. Viral encephalitis, particularly herpes simplex viruses or enteroviruses, this one supported by the history of the fever, poor feeding, lethargy, encephalopathy with possible seizure. On examination, hypertonia with upper motor neuroscience. However, the points against in this diagnosis is child have a hepatomegaly and severe transaminitis. Yes, some infection like herpes simplex viruses will have transaminitis, but it's not very severe in this, like in this case. I would like to obtain more history to support my differential diagnosis. I need to ask regarding the behavioral change, irritability, seizure, and vomiting, and then look for any focal neurological sign and do fundoscopy to look for the raised intracranial pressure. So we proceed to the second differential diagnosis, which is sepsis-associated encephalopathy. This is supported by the fever, altered mental status, shock, hepatomegaly with hypoglycemia. However, in the on examination and hypertonia with upper motor neuroscience, this usually caused by the primary brain infection such as meningitis or encephalitis. And in this case, the patient has a severe transaminitis, but there is no significant acute kidney injury, which usually sepsis will present with systemic manifestation. But I still need to get more history to look for any associated symptom and to look for the source of infection and any reduced urine output. My third differential diagnosis will be acute liver failure with encephalopathy. The possible cause could be infection, toxic ingestion, or inborn error of metabolism. This supported by the preceding viral illness, lethargic, poor feeding, and encephalopathy, hepatomegaly and hypertonia and hyporeflexia. Child also have hypoglycemia with severe transaminitis with conjugated hypovolemia. However, there is no jaundice in this presentation, but it does not exclude the acute liver failure. It cannot exclude the acute liver failure. So I would like to get more history regarding the abdominal pain, any GI loss, any weight loss, any recent water activity and water source, and any easily bleeding or bruises. We need to look for any dark color urine, and then need to rule out any sign of chronic liver disease. Look for ascites, edema, and digital clubbing. My fourth differential diagnosis, this was exclusively associated with my third differential diagnosis, inborn error of metabolism, which is particularly important, particularly mitochondrial disorder, fatty acid oxidation, organic aciduria, urea cycle disorder, and glycogen storage disease, as this one primarily can presented with transaminitis. So the points toward the inborn error of metabolism is the rapid deterioration was triggered by the infection, encephalopathy, hypoglycemia, hepatomegaly, and poor weight gain. However, in absence of the prior episode and normal development, make this diagnosis are less likely, but it's still possible. So we need to ask more on the history and examine history to ask regarding any feeding, any prolonged fasting, any recent dietary change like high protein diet, any previous episode of unexplained vomiting and lethargy, any seizure, any prior hospital admission, poor feeding as a unit, consanguineous marriage, and history of a family. On examination, I would like to look for the head circumference, and then look for dysmorphism as cause face can be happen in the glycogen storage disease. My fifth differential diagnosis is acute toxic injection and drug overdose. It should always be considered in the child with acute with transaminitis and encephalopathy. And then once supporting is acute onset with encephalopathy and severe transaminitis. However, hepatomegaly is not due to occur, and in the preceding 5 instance, the diagnosis of primary drug overdose is less likely. However, medication exposure cannot be excluded as the medication will be administered during the illness and it will contribute to the toxicity. So I would like to get more history regarding the medication history. Any medication given, if paracetamol given, you need to ask either is the appropriate dose given, and then any additional injection like salicylic poisoning, sodium valproate, traditional and herbal medication, and toxic exposure. Come to my last two differential diagnoses. This is first it is a Rice syndrome. Rice syndrome is considered in the combination of the viral illness, encephalopathy, hypoglycemia, and hepatomegaly with no jaundice. However, this syndrome is rare, and then we need to consider any history of aspirin exposure. My last differential diagnosis is acute rheumatic encephalopathy. This is supported by preceding infection, rapid neurological deterioration, and encephalopathy. However, hyperglycemia and hepatomegaly is unusual, but you need to ask any recent viral illness such as influenza or varicella zoster infection. That's all for my differential diagnosis. Okay, thank you, Dr. Faiqah. Dr. Chong will give you the information that you need. So Faiqah, for the history obtained from the parents, there was no vomiting or diarrhea. The child was well prior to the 3 days of illness, and there was no recent for the past 1 to 2 weeks. There was no change in the diet, and there was no noticeable change in the patient's urine output and the color of the urine. Even though the child was not well, there was no any medication given, and no traditional remedies was given to the child. The parents had no concern on possible drug or toxin injection. However, from further history, you notice that the child had previous admission when the child was 1 year old to a district hospital. Diagnosis given at that time was initially influenza infection, but no liver impairment. The child was required blood transfusion and was being followed up, and the fluoride liver enzymes all had been normalized, and the child was totally fine and well in between the admission at 1 year old and currently at 2 years old. There was no consanguinity, and there was no family history of neonatal death or liver diseases. This family lived in Jalan Tut in a terrace house, and there was no recent traveling. When we plot the head circumference, it was at the 25th percentile, although the child was small, but the weight gain was around 10 centile. There was no signs of chronic liver disease, and there was no ascites. Thank you, Dr. Chong, for the further history and examination. In this case, I would like to approach just systematically. First, I would like to perform a bedside blood investigation. We started with the blood gas and lactate. For the high and iron gap metabolic acidosis to be happen in sepsis, metabolic disorder, and shock, and high lactate in mitochondrial disorder, organic aciduria, severe shock, and liver dysfunction. And I would like to get more component on the liver function tests, such as albumin level, global glutamate transpeptide, GGT, and alkaline phosphate. High GGT and ALP will sign of cholestasis in acute liver failure, and hyperalbuminemia will occur in sepsis and chronic liver failure. I also would like to look for the coagulation profile. This is an important marker for the liver synthetic function and will help to in diagnosis of the acute liver failure. The pollen proton bintang is more than 15 second and INR more than 1.5 is one of the criteria for diagnosis of acute liver failure. I also need to look for the high ammonia because the child with acute liver failure, the high ammonia in which you support the diagnosis of acute liver failure with hepatic encephalopathy or urea cycle disorder. For the serum ketone, I would like to do to help in diagnosis of the metabolic causes, low ketone in the fatty acid oxidation defect and high ketone in organic aciduria. This is an immediate imaging that I would like to do. In the patient presented with encephalopathy, I would like to do a CT grade to exclude any intracranial bleeding, any space accumulation, and then also in several edema with the patient with hepatic encephalopathy. I also would like to do the ultrasound hepatobiliary system in the patient with the severe transaminitis. We need to assess the liver parenchyma and vascular flow, exclude the obstructive causes. My expected finding in ultrasound hepatobiliary is the hepatomegaly with or without increased echogenicity, suggestive of hepatocellular injury and metabolic disease. Okay. Faiqah, your differentials included infection, correct? Right. So, what other investigations would you do to rule out those infections? For the differential, my one of the differential is to be infections. Okay, so I would like to do the blood culture, look for the CRP and procalcitonin, and do the viral workup on this patient. Also, in this patient, also I would like to do the lumbar puncture. By that, I need to stabilize and to make sure the patient to stabilize first before I proceed to the lumbar puncture. And what would you say? For the lumbar puncture, I would like to look for the high if in my diagnosis is a viral encephalitis, maybe high white blood cell count with lymphocyte predominant, high protein with and then we also will send with PCR multiplex to look for the viruses. Another differential diagnosis is acute hepatitis encephalopathy. So will be normal cell count that is increased in protein in that diagnosis. Okay. Okay, I will show you the initial investigation that we sent when the child was sent to our center. So CT brain was done. There was no intraocular hemorrhage and there was no cerebral edema. And this is the initial investigation that we obtained. Okay, Chong. These are the initial investigation. There's a metabolic acidosis with a high lactate. PT and INR was prolonged with hyperammonia and transaminity with conjugated direct hyperbilirubinemia. So based on this investigation, my provisional diagnosis will be acute liver failure with hepatic encephalopathy. Sorry. So what was the anion gap? Yeah, that's because one of the investigations you asked for was to look at the anion gap. Yeah. Do you have enough? Enough information to count for the anion gap because I still need a chloride and does Dr. Chong have the information? So the initial sodium was 135 and chloride is 110. So my calculation it was 10. That my calculation is anion gap is 10. It's not It's not high, it's a level and iron gaps.
Alright, okay. So based on the investigations and information that has been provided to you, can you rule out some of your differentials?
Based on the investigation, yes, I can rule out the infectious causes, which are viral encephalite. Sorry, based on the investigation. Actually, I cannot rule out the virus causes, but then I can rule out my differential, based on the investigation is most likely diagnosis will be acute encephalitis, acute liver failure with hepatic encephalitis.
What about some of the metabolic disorders?
The metabolic disorder, urine ketone was not sent. However, I will proceed to the baseline. I will proceed to the other investigation, such as baseline metabolic investigation.
So just looking at the results that you have here, do you think it's likely to be urea cycle disorder or organic aciduria?
For the for the urea cycle and aciduria, I think it's a less likely.
But what would you expect to find if it's a urea cycle defect?
We look for the high and iron gap of metabolic acidosis, and then the lactate will be high, and then the ketone will be
urea cycle. Would you expect a higher ammonia?
No.
In a urea cycle defect?
Sorry, yes. I would have expected the high ammonia in the urea cycle defect.
Okay. In organic aciduria, would a lactate of 2.8 point towards an organic acid, or would you expect a higher?
I will expect a higher lactate.
Right. Okay. So what about your other differentials such as Rye syndrome? Can you rule out Rye syndrome based on this?
Syndrome. But it's this understanding hepatomegaly without a jaundice. Actually, a bit difficult to work with this detection.
You still need to explain other things first before you say this is amazing. Okay. Okay. Right, Dr. Chai to present the findings on CT brain.
Hi, good morning. Thank you, Prof. I'm not presenting CT brain. The CT brain was done in the referring hospital. So what we have here is the ultrasound that we done at our center. So this is the ultrasound done at this date, the 11th of November. You can see that the patient has rather normal liver chymicrogenicity. Well, there's a bit of a borderline hepatomegaly where I measure the liver span is about 10. And also there's no focal liver lesion you can see. Inside there also we did not find any dilated intrahepatic ducts. And these are two images of what we call, we use a linear probe to have a higher resolution image to examine the surface of the liver to look for any irregularity, any signs of cirrhosis. So you can see that the liver surface here, the mouse is not very nice. The liver surface is very smooth. Okay, this is the center image of a right liver lobe. Okay, small liver surface is no mobility. Same goes to the left liver lobe. And inside here, we can further investigate the very small intrahepatic ductal dilatation. So next is the vessel. So the main blood supply to the liver is the portal vein. So we examine the size of the portal vein, 0.45 cm is normal for this age group, and we examine whether there is any thrombosis or any color pepper flow defect. This is when we take on the color pepper, you can see that the color pepper is of normal, there's no filling defect. There's no filling defect, and also the color flow direction is normal. We want the portal vein to flow to the liver parenchyma, not away from it. So this red color usually means that the flow is towards the upper output. That depends on the setting. So the next, apart from the portal vein, we have to examine. We also need to examine the hepatic veins, right? Because when we get the referrals of acute liver enzyme derangement, sometimes we want to examine whether it could be bacterial or not. So these are the image that we took for the left hepatic vein, the middle hepatic vein, and also the right hepatic vein. Sometimes the right hepatic vein is a bit difficult because you can see the lung is already starting to obscure part of the liver parenchyma. This is the inferior liver cava and the hepatic segment, which are all patent. And the flow direction is very normal. You can see that they flow into the IVC. So this is the gallbladder. Gallbladder is distended, adjacent to it, the liver parenchyma has a bit of hyperdensity. But that's not non-specific and not very important. The other thing is there's a spleen. This is the visualized spleen. The spleen is normal. There's no splenomegaly for this patient. And we also check for the splenic vein to see whether it is thrombosis or not, because splenic vein is part of the tributary for the portal vein. So when we get the referral of acute liver failure, they want to examine, and particularly if the patient has fever. So these are the usual things that the radiology team will be looking at. They are looking for, so sometimes if we have acute hepatitis, you have reduced ecogenicity of the liver parenchyma and make the portal triads structure become very dry. This is the style-like appearance. But this style appearance is not it's not specific just for acute hepatitis. You can see there's a long list of things that can happen and give you the same appearance of this. Okay, the other thing is, of course, we want to see chronicity, the features of chronicity, chronic liver failure, which is the end result is liver cirrhosis. I mentioned just now for the liver surface irregularity and also blunting of the liver image. Okay, sometimes you also need to check for the cardiac lobe hypertrophy. Bacteria, I mentioned this is an example from the internet that the patient have a bacteria. You can see a very large thrombus, ectotomic thrombus in there. And we see some of the thrombus extending the left hepatic vein. And when we put on color bacteria, sometimes if we do not see the main hepatic vein, sometimes we see the collateral. Collateral vessels are those curvy linear-like vessels that are not supposed to be there because the liver veins and also vascularity, they are branch type, they are curvy linear type of this. So this indicates that there is collateral and there is bacteria. Okay, but it's not in this patient. Another thing is the portal vein thrombosis. Okay, this is the thrombus that pack the portal vein and also towards the right portal vein here. And also when you put on color bacteria, sometimes there is partial flow, there's no flow, there's reverse flow. In the chronic case, you can see cavernous transformation of the portal vein, which means that the collateral vessels try to form around the portal hepatis and give you an appearance of cavernous. And of course, if a patient with a fever, fever with increased white blood cell count, we also wanted to exclude any focal liver lesion, particularly a large liver abscess collection. All that are not in this patient. Our patient have, sorry, I'll go back to one slide to conclude the ultrasound examination. We found hepatomegaly, but there's no other supporting features to such as any vascular thrombosis or any focal liver lesion or any chronicity of the liver disease.
Okay, Dr. Chai, looking at the list of differential diagnoses, how would an ultrasound help us rule out some, or would it help us rule out some?
Ultrasound only try to exclude the structural causes. For example, obstructive causes, but I don't think that the very obstruction is anyway in the differential diagnosis because the bilirubin, which is not is in the conjugated bilirubin. So in this kind of cases, the mainstay of ultrasound is to differentiate the acute and also the chronic liver parenchyma changes. Just to have a guide for clinician in terms of whether we are dealing with an acute episode of illness or there is actually a problem changes in the liver parenchyma. And to exclude from the differential, the ultrasound is not very helpful in excluding your differential diagnosis to be very just confirm back your physical examination finding that this patient had hepatomegaly. Alright, but there is no other features that we can have.
Okay. Thank you, Dr. Chong.
Thank you, everyone.
Okay. Great. So Dr. Faiqah, so you've had initial investigations done, right? So are there any other investigations do you think that will be helpful? I will proceed for my further investigation. For this pressure, I will look for the cause of the acute liver failure. I will also do the I will look for the metabolic screening, do the IEM screening that plasma organic acid elevated RNA in mitochondrial disease. Urine organic acid will diminish in the organic aciduria and mitochondrial disease, and dry blood spot acid-carnitine will diminish in the fatty acid oxidation. As my differential also is toxic injection, so I will look for the paracetamol level, and then the toxicology screening, appropriate toxicology screening based on the diagnosis that we get. This is this is the infection throughout the infectious cause. This investigation for the infectious. I will do the blood culture, C reactive protein and procalcitonin. But I also want to do the virus screening, and then to look the other cause, the common cause of the acute liver failure. So I will send for the leptospira IgM, virus screening like hepatitis A, B, C screening, especially multiplex PCR to look for enterovirus and adenovirus, cytomegalovirus, Epstein-Barr virus, herpes simplex viruses, and human herpes viruses types. Actually, initially I would like to consider a CT brain. If the initial result are inconclusive and then the result is inconclusive, we will have to refine more on the differential diagnosis. Okay, that's from the investigation. Okay.
So we have sent a paracetamol level, although the patient, by history, there was no PCM injection. So the level was undetectable. Extensive infection screening were being done. Blood culture were negative. Leptospira IgM was negative. Since the child has some respiratory illnesses, the human metapneumovirus PCR was detected. And otherwise, the other infectious screening were negative, including hepatitis screen, CMV, PCV, EBV, and herpes simplex IgM. Even though the history less suggestive of inborn metabolism, it was being sent, and all those investigations were not diagnostic profile, and some of the investigations show that it could be consistent with liver impairment. Autoimmune disease was being screened because this is a recurrent acute hepatitis, although there was no chronicity, and it was
So the based on the investigation given, it's a diagnosis, the provision diagnosis acute liver failure, hepatic encephalopathy, but I need to look for but it's still not sure the cause of they still cannot find the cause of the acute liver failure. So we need to investigate more, and we need to investigate more, and then we really need a consultation from the yes.
Right. So what are some of the causes of acute hepatic encephalopathy that can that's a broad
diagnosis. So usually we already rule out the common infection, and then rule out the toxin and the but I think in this chart we have a recurrent acute liver failure because by the history given. So I think we need to ask more regarding the family history, any other metabolic rare metabolic causes that can cause the acute.
Okay, so eventually we were not sure what was the etiology for acute liver failure for this child. But majority of the children with acute liver failure, we couldn't find the cause. This is contribute to about 30 to 40% of them with acute liver failure. So the cause of illness of the child required low respiratory support, but required moderate vessel pressure requirement. She was being transfused fresh frozen plasma, initially in preparation for CRRT. Her ammonia was reduced to less than 150 billion hours without dialysis. She was given vitamin K, lactulose, and given empirical antibiotic and antiviral. Glucose was stable with GIR of 4 mg per kilo per minute. She was extubated after 3 days, and the total hospital stay of 11 days, and she was back to her baseline before discharge. This is the liver function before she was discharged. Not entirely normal, but markedly improved. There were ongoing consultation with our gastroenterology colleague in other hospital and metabolic team, and was giving follow-up with the teams.
Right, so maybe we can invite Dr. Leong. She's online.
Hi, Leong from Hospital Tunku Aziza. So, you all can hear me clearly?
Yeah, we can. Thank you for coming,
Can you all
Dr.
hear me?
Yes.
Yeah. So I will, can you all see my slide?
Yes.
Okay. So I will talk briefly about this child. So basically, this child was first referred to us when she is at 2 years, 2 months old. So we can see from the history actually, this child having the first episodes of acute liver failure when she is 10 months old in September 2023. You can see she presented with a very short history of influenza-like illness with fever. That time she is tested positive with influenza A, and you can see again the liver enzyme is markedly elevated, and the INR is 3.3, while the ammonia is still slightly high, but it's still not at the dangerous area. That time they did work out for the causes of the acute hepatitis, which including your IEM, your infection, all were negative. So she was discharged well. Subsequently, actually, she remains well without any febrile or infection occurs. But this is at the 1 year, at the 2 years old, November 2024, when she presented again with fever and this abnormal behavior, which she was admitted to UKM that time. So I think they presented, you can see here, she also in another episodes of acute liver failure, which her INR is 2.824 and elevated enzyme. So she was ventilated and cephalopathic, and she was managed conservatively with supportive care, and she recovered well with discharge with a normal INR and almost normal enzyme. So we can see here from here, she got this recurrent acute liver failure episodes triggered by a febrile illness. So she's first come to our attention is in December 2024. It's like after 2 weeks she discharged, she again have a fever and flu-like symptoms. So she presented to the district hospital again, and they noted that the liver function again in acute liver failure. So that time the ammonia is very high at 135 with a high lactate of 2.3. So thus she was referred to our center for acute liver failure. So further history, I think just now the MO presented. So there is no significant family history or consanguineous marriage. She is the youngest, and all other siblings are healthy, and her developmental milestone is okay, and there is no traditional medication or supplementations. On examination, there's no stigmata of a chronic liver disease. This is a well-tried child. She's not jaundice, not encephalopathic when we saw. And she has no sign of chronic liver disease. Liver is soft, 3 cm palpable, and there's no ascites and splenomegaly. So you can see again our investigation for infection, autoimmune causes, your metabolic causes, and even the ultrasound abdomen, it show that it's normal findings. So this time, again, we are support her by just monitoring her GCS, sugar, and then monitor her liver function. After 7 days of admission, we can see that her INR normalized and her enzyme also markedly improved with a normal ammonia. So that time, in view of this is the third episodes of recurrent acute liver failure, it's very likely that we think it's a genetic causes. So she was counseled, and unfortunately, family had no funding for the genetic testing. So she was discharged, and then we review again after 1 month, and this time we can see that the liver function test is completely normal and she is well. So another 3 months we see back in between, the family managed to get the funding for the genetic testing, and the genetic testing actually the result come back as a she has a variants pathological variants of this NBAS gene mutation, which associated with a disease of a recurrent liver failure. So she was counseled and explained about the management, especially during febrile illness, and we follow up her accordingly. So the last admission to us is actually is October last year again. She presented with a febrile illness and slightly encephalopathic. That time she had influenza A infection. So we can see after like a week of monitoring and supportive care, her liver function also improved and her INR also normalized with a slightly raised liver enzyme. She was discharged well and currently under our follow-up. So I want to explain a little bit about this pediatric acute liver failure, which we can use a mnemonic of ABC, which acute onset of liver disease without evidence of a chronic liver disease previously. And this child show a biochemical evidence of a severe liver injury with a coagulopathy not corrected by vitamin K, because some child, when they have cholestasis, they might have this coagulopathy. So it's always good that we give a trial of IV vitamin K and see whether the coagulopathy is corrected or not. So if it's not corrected with a PT of more than 15 seconds on INR and more than 1.5 with evidence of hepatic NCAP, or if the PT is more than 20 seconds or INR or more than 2 without encephalopathy. So this is a definition of acute liver failure. We know that this is a very dynamic process for acute liver failure. So timely recognition is very important, because we need to anticipate, prevent the complication, and with referral to a liver transplant center if necessary, as it may improve the outcome. So we can see that, as mentioned by the Chong, so the cause of a pediatric acute liver failure, a lot of time actually we can never find a cause in up to almost 50% of cases. So we can see that based on various literature, the indeterminate causes is very high. While others like infection, your drug-induced liver injury, your metabolic cause, or even your autoimmune cause, it depends on the region as well. So like the developed country, they are more to these autoimmune causes, your metabolic causes, and drug-induced causes. While in this developing country, infection is still higher in the list for these causes of acute liver failure. But with improving of this, our standardized diagnostic approach, in particular in introduction of more this genetic testing, so we can see that actually the cause of this indeterminate a percentage is reducing. Means that we can diagnose more of these inhibitory causes of acute liver failure. So I think very important that we need to know that the etiology of this acute liver failure, we can use a mnemonic of DIAM, DIAM, which is divide into your metabolic cause, infection, or your ischemic vascular cause, your autoimmune cause, and your metabolic cause. Is also based on the age of presentation of the child, because we see that some causes is more common in neonates and infants, some is for older kids, like metabolic causes. Neonates, if they're presented, is like lactosemia, thalassemia, your urea cycle defects, and your gestational autoimmune liver disease. While like infants, your fatty acid oxidation defect, while in toddler or older children, Wilson's very commonly they might present with acute liver failure, while infection, some are more common in certain age groups. So other causes like in neonates, all those undergo a cardiac surgery. In infants, like severe asphyxia, your cardiac surgery, and your myocarditis. And for drugs, very common is your paracetamol. Either is intentional or unintentional injection in the older children. While autoimmune hepatitis is after the age of infant or toddler age group, while your malignancy or HLH is more common in your neonates or smaller child. So again, your clinical presentation is based on your age and etiology. Usually they will present very non-specifically with prodromal symptoms like fatigue, lethargy, some nausea, vomiting, and abdominal pain. So we can't really identify these children usually until they have jaundice, and when the doctor do a blood test, or when they have a rapidly declining liver function, they present with coagulopathy, bleeding, or encephalopathy. So we can see that the natural history for your acute liver failure is either the child slowly recovered, or the child didn't go into a progressive liver failure and require a liver transplant, or eventually the child succumb without a transplant. So history checking is very important, again based on your history, like infection, your drugs, autoimmune causes, and your metabolic causes. And physical examination, we need to see how is the child general condition, the hydration status, any risk of this spontaneous bleeding, and evidence of, we should look for evidence of chronic liver disease. Initial and serial neurological examination is very important, because they may progress to a hepatic encephalopathy very quickly. So your mental state and your neurological examination. So we know that assessment of your hepatic encephalopathy in children is very challenging, especially in the older children, but it's always based on our regular assessment and serial examination. So we need to be very vigilant, because if the child have a hepatic encephalopathy, it might need an urgent referral and management. So the investigation we need to do general testing, like your renal function, your neurological examination, and your electrolytes, and your liver specific test, like our liver function test, AST/ALT, your bilirubin, albumin, coagulation profile, your glucose and ammonia, and age-based diagnostic investigation, like I mentioned earlier, because we need to identify the etiology as soon as possible to plan our management accordingly. So this is the list of the investigation which we can get in the books. Or so we can see it's very extensive list of investigation based on your drugs, infection, autoimmune causes, and your metabolic causes, and based on the age. And we also can plan some accordingly, like for autoimmune, we will do when the child is like infants or elder child. While if this is a neonatal acute failure, neonatal acute liver failure, we might want to do a gestational autoimmune liver disease screen for these infants with acute liver failure. So we can see that if the child fulfill the criteria for acute liver failure, the initial evaluation is still your history, then investigation, and based on the age group, there is a certain diagnostic test that we want to do, and based on our suspicion. So the management mainly actually is supportive care. Meanwhile, we need to monitoring for any complication like cerebral edema, which we need to support accordingly, and the respiration. The monitoring including your sugar, your vital sign, your IO, and your electrolytes, and your liver function test definitely. And there is some like paracetamol toxicity. There is a specific therapy like NAC, your galactosemia, you give a lactose-free diet, and your gestational autoimmune liver disease, you can give a double volume plasma exchange, what IVIG, and your autoimmune is your steroid. So we always need to assess, do a severe investigation and clinical examination to make sure that the child is don't have a progressive encephalopathy, hepatic encephalopathy, which the child need to refer for a liver transplant assessment. So it's always very scary to see that their coagulation, your INR is like more than 10, more than 5. So bleeding actually is not that common in a pediatric acute liver failure because they have a reduction in both the anti and poor coagulant factors. We didn't recommend you to correct the coagulopathy routinely unless you need to do a procedure or unless there is a clinically overt bleeding. So I talk a bit about recurrent acute liver failure. Basically, it's a group of this genetic disorder that they predispose to this acute liver failure due to some trigger like fever, infection, fasting, and stress. And most cases, the liver function actually will recover in between. And this divide into 4 groups, which including your 2 of the urea cycle disorder, your 2 of the mitochondrial disorder, your disorder of protein translation, and vesicular trafficking, which in this child, the NPAS mutation. So this disorder of vesicular trafficking, the NPAS mutation, actually, this disorder is autosomal recessive. So far, there is 346 gene identified is linked to these human diseases, and this different phenotype depends on what is the defect in their component of the trafficking system gene. And only 3 actually cause the recurrent acute liver failure, which including your NBAS gene, your RING1 gene, and SCYL gene cause the Kaufman syndrome, which is low low GGT cholestasis, acute liver failure, and neurodegeneration. So we can see that actually disturbed in this vesicular trafficking, you can cause defect in this anterograde and retrograde transport and cause the endoplasmic reticulum stress, and which induce the hepatocyte cell death when there is a trigger like your febrile illness. So this NBAS gene mutation actually will present very heterogeneously because some will present very early, some might present a bit later, even in adult. But usually, the febrile illness, they will trigger the first liver crisis or acute liver failure in infancy, like in these children. But with age, they will be in a decreasing frequency and severity. So we can see that in this child, she fit quite nicely into the table of this NBAS mutation with infant liver failure syndrome 2, which the age of onset is during infancy, triggered by a fever, infection, and she is have a bit of what you call facial flat hypothyroidism in this child actually. But her height is still okay, and nervous system so far, the CT brain didn't show any brain atrophy. So there is no specific therapy or curative therapy, and advise about this emergency treatment during the febrile infection. They need to go to hospital to get their liver function test and monitoring. Education is very important, and early antipyretic therapy. There's always a question about liver transplant in view of most of the child, they may recover spontaneously, but there is few reported cases that they did transplant of this child with a good outcome with no recurrence of liver crisis after the transplant. So, in summary, pediatric acute liver failure is a very rapidly progressive disease with high mortality if without urgent evaluation, management, and liver transplant. So, this pediatric liver failure patient required a close evaluation for presence of this hepatic encephalopathy, as it might help us to dictate our management and intervention. So current management is still to supporting the failing liver and other organ, pending either is spontaneously recovered or the child require a liver transplant. So in view of this advanced and this disorder of vesicular trafficking associated disease is very not common. But if a child with recurrent acute liver failure, we should ask for early genetic testing to identify this group of patients. Okay, I will stop my presentation. Thanks.
Thank you very much, Dr. Leong, for that overview. In the constraint of time, I think I'll invite Dr. Chong to talk about the management next.
So in the next 5 minutes or so, I will give a quick overview and summary on how we care for a patient with acute liver failure in intensive care unit. So for the knowledge of medical students, we know that liver has a lot of functions. Mostly the main functions including synthetic function, storage function, metabolism, and detoxification and drug metabolism. With this knowledge in mind, therefore, we know that how patients present with acute liver failure means all those functions fails, which they have coagulopathy, hyperglycemia, high bilirubin, and high ammonia. And some of the patients, when they are very severe, they can manifest with multi-organ dysfunction. And the liver enzymes that we send usually NCLT is not liver function by itself, but actually is indicators of liver injury. So many of the children with acute liver failure require ICU admissions, mostly because of they have reduced in conscious level, when they have higher grade of hepatic encephalopathy, when they require ventricular support, inotropic support, and many of them will develop hepatorenal syndrome with liver with kidney failure. So at times when the organs are not markedly failed, but we need to closely monitor the patients, those patients need to be admitted in ICU in anticipation of further deterioration. And mortality rate of these children, especially in center without liver transplant, is as high as 30 to 40%. But there's hope because the liver is the only visceral organ with the capacity of regeneration. With minor injury, the regeneration can occur spontaneously, but even though with major injury, when we support and treat the patient adequately, the liver can regenerate. Of course, the process is complicated, involving regulated inflammatory response and also growth factor activation, but those processes will be regulated by proliferation inhibition. So as Dr. Leong had showed you, the cause of illness can be rapid and unpredictable. What we need to do is support the patients throughout the process in the bridge towards recovery or liver transplant to certain patients. So early recognition is important. Monitor the cause and treat when there's a disease-specific intervention is available, and support the child adequately until recovery, liver transplant, or sometimes we need to take time for the investigation results to be available. We need to support the child adequately. The ultimate aim is to promote spontaneous regeneration of liver if the patient not required liver transplant. So the principle of management is systematic. We should be systematic and pathophysiological-based therapy, including etiology-specific treatment, if that is paracetamol poisoning, if there is infection, or if even a viral metabolism. Support and prevent organ dysfunction by optimizing a patient's hemodynamic and metabolic and electrolyte homeostasis. So cerebral edema and sepsis is a major cause of mortality and death in children with acute liver failure. Therefore, we need to diagnose, prevent, and treat hyperammonemia adequately to prevent hepatic encephalopathy and prevent and treat infections aggressively. So, not all children will recover. At certain stage, some children might need to be evaluated and organized for liver transplant. So, the whole process involves a huge group of people. Therefore, the collaboration in between intensive care unit, gastroenterology, metabolic team, sometimes toxicology team, and transplant center is essential. So I will talk a bit more about hepatic encephalopathy. It's a group of neuropsychiatric impairment and mental state changes that present in patients with acute liver failure. The underlying etiology is not well defined, but most understood mechanism is because of ammonia. So ammonia is a byproduct of bacterial metabolism of our protein and nitrogen compounds in our large intestine. In a normal liver, the liver will metabolize into urea and excreted in the urine. However, when the liver function fails, ammonia will be accumulated across the blood-brain barrier, causing neuroinflammation and cerebral edema. Other toxins are involved, including bile acids, aromatic amino acids, and cytokines. So Dr. Leong had mentioned briefly about grading. So it's not easy to assess neurological status in children. And other conditions such as when patient is severely ill, had metabolic derangement, has electrolyte problem, hypoglycemia, when the hemodynamic is not stable, all these can confound the assessment of the child with hepatic encephalopathy because all those problems also can make the child to aborted conscious level. So hepatic encephalopathy can be prompted and precipitated by sepsis in the presence of GI bleed, dehydration, constipation, or ileus. So how do we treat? Medically, we need to mitigate the ammonia level by giving lactulose to produce 3 to 4 times loose 2 per day. Some centers give bowel decompensation with oral antibiotic like neomycin. This patient was received gentamicin. At the initial phase, we might need to consider to reduce the patient's protein intake down to 1 gram per kilo. Patients need to be closely monitored. When there are signs of increased intracranial pressure or cerebral edema, we need to be aggressively monitor the patient, the neural condition, and also neural protection. So the mainstay is patient need to be intubated and to maintain the adequate cerebral perfusion. And all the strategy that we use is extrapolated from the pediatric traumatic brain injury guidelines. Monitoring is important, including transcranial Doppler and optic nerve sheath diameter monitoring. Some centers even insert an intracranial pressure monitor to monitor the patient. Some patients' ammonia level is very high, in which they require renal replacement therapy. Ammonia is a water-soluble compound, so it's effectively removed by renal replacement therapy with the mechanism of diffusion and also convection. Generally, patients who had hepatic encephalopathy grade 3 to 4 or ammonia, which is uncontrolled, more than 200, required renal replacement therapy. Other indications for renal replacement including kidney injury, when patient is oligulic, hyperkalemic, or fluid overload. So there are growing knowledge about liver as another organ which is very robust in their immunity. And so this plays a role in causing systemic inflammatory response and multi-organ dysfunction when patient has acute liver failure. So when there's liver injury occurs, there will be local productions of cytokines and other inflammatory markers, and that leads to liver regeneration. However, when this process is dysregulated, it can cause systemic effect that leads to activation of macrophage, systemic inflammation, multi-organ dysfunction, and contributing to hepatic encephalopathy. Therefore, immunotherapies has growing roles in patients with acute liver failure. The aim is to dampen the severity of disease and improve survival by reducing inflammation, mitigate circulatory failure, and also sepsis. So in many centers, we use high volume plasma exchange, and there's strong evidence in adult studies in which it improves the transplant-free survival. In children, the evidence remains a small case series. How about steroids and immunoglobulins? Apart from autoimmune hepatitis, it is controversial. The basis is that there will be a lot of immune dysregulation in patients with acute liver failure, but evidence in children series remains low. Other extracorporeal liver support, which is not available in glaciers as such, and there are experimentable advancement apart from liver transplant. There are growing novel therapies in terms of other type of transplant, including mesenchymal stem cell transplant, and so also infusion of hepatocyte through the portal. So Dr. Leong had mentioned that this patient had INR of more than 10, but the bleeding risk actually is low. And some children, they're even in the hypercoagulable state, and transfusion is required when the patient has bleeding or invasive procedures is required. So the key message we want to convey across from this CPC symposium is that encephalopathy in children is not easy. We need to think beyond the etiology outside the brain, and acute liver failure in children has high mortality and morbidity. Therefore, we need to know how to approach these patients timely, identify the cause if able to identify and treat it. And meanwhile, we need to have a meticulous pathophysiological-based critical care for this patient in order to improve the outcome. Never forget to involve other teams, especially when you are uncertain. And certainly, a team works together to improve the patient's outcome. With that, I thank you. Thank you, Dr. Chong. It's already 9:07, so I would like to thank all the speakers for the interesting discussion this morning. I think the medical students, you've got your quiz yet, so please stay back and answer the quiz question. Thank you, everybody.